so you guys can hear me. The House Insurance Committee will come to order. Would the clerk please take attendance?
Chair Harris,
Here.
Representatives Tisdale,
Here.
Leitner,
Here.
Posterman,
Here.
Aragona, Nyer,
Here.
Schutte,
Here.
Carter,
Here.
Tate,
Here.
Fitzgerald,
Here.
Whitsett. Mr. Chair, you have 9 members present, a quorum.
Thank you, sir. Can I have a motion to approve the minutes from the May 21st meeting? And Rep. Leitner makes that motion. See if no objection, the minutes are approved. All right, today we have a presentation from the Michigan Hospital Association, and I believe joining us today is Elizabeth Cutter, Senior Director of Government and Political Affairs, and Laura Appel, Executive Vice President of the Michigan Hospital Association. Ladies, thank you for joining us, and look forward to your presentation whenever you're ready.
Awesome. Thank you. Thank you in advance, Mr. Chair, members of the committee, for having us here. We're really excited to be here and very honored. Thank you for the opportunity to present today on a couple of pressing issues specific to cost drivers in the healthcare space. As you already noted, my name is Elizabeth Cutter. I'm the Senior Director with Michigan Health and Hospital Association. And as again already noted, this is my boss, Laura. She's the Executive Vice President for Government Relations and Public Policy. The MHA has the privilege of representing all 129 acute care hospitals in the state of Michigan, in addition to several of our freestanding behavioral health hospitals and long-term acute care hospitals. Michigan hospitals are more than healthcare providers. We're cornerstones in the community. From the Detroit area to the Upper Peninsula, hospitals across the state are open 24 hours a day, 365 days a week, days a year, 7 days a week, 365 days a week. I can't get that one right. We're open a lot. We're open all the time. Thank you. I can't get that right. Providing emergency care and acute care to anyone who walks through our doors. Hospitals are economic anchors, and we'll talk a little bit about the economic impact that we have. And we're the largest employer, largely in many of your districts. We're stewards of public health and providers of charity and community investment. Beyond our 4 walls, Michigan hospitals contributed more than $4.5 billion last year to funding community impact projects like mobile health clinics, transportation and housing support, food pharmacies, behavioral health programs, and more. Our hospitals partner with local schools, churches, and nonprofits to meet hospital, healthcare, and social needs of the community. Our hospitals are deeply vested in the well-being of the communities we serve and the patients we treat, the people we employ, all of this while navigating immense financial strain. Hospital expenses are increasing, growing nationally in 2024 by 5.1% and outpacing the overall inflation rate of 2.9%. The dominant reasons for increased expenses for healthcare workers are prescription drugs and supplies, as well as labor. I'm going to start by talking a little bit about workforce and talent development. In addition to the economy of what we do globally, healthcare is the largest private sector employer in the state. Hospitals employ more than 220,000 people who provide $10.4 billion a year in tax revenue. Nearly 1 in 5 jobs in Michigan is directly related to healthcare, and last year hospitals in Michigan hired more than 58,000 people. Despite the effort hospitals make to hire staff, the demand for healthcare sector employees remains extremely high. Here is how many people we hired last year, as well as the number of people that we are in need of will be next. As of early 2025, our member hospitals reported 23,000 vacancies. As you can see on this slide, nursing continues to be the highest number of people that we need in demand. And nationally, across all specialties, we've got a projected shortage of about 187,000 physicians. For reference, 72 of our 83 counties here in Michigan are designated healthcare professional shortage areas. While we've seen significant gains through partnerships and support at the state level for healthcare careers, we are swimming upstream. We're battling against non-healthcare employers for top talent, and the demand for competitive salary and benefits increases yearly. Labor costs typically represent about 56% of our total expenses, and that's climbing and regularly very competitive. You, your loved ones, and your neighbors deserve the best care, and hospitals are focused on recruiting, retaining, and training high-quality healthcare providers here in Michigan to provide that care. We will continue to work with you and find and implement policies that keep talent in Michigan, support healthcare career pathways, and ensure our hospitals have the teams in place to serve you. Prescription drugs, my favorite topic. A persistent and growing cost pressure that we continue to see is increasing drug prices. National drug spending continues to increase annually, upwards of $449 billion of the United States. In the United States is what we spend on drugs a year, and hospitals spend about 25% of that. The median price of a new drug entering the market in 2023 topped over $300,000, which is a 35% increase from the 2022 median price. Further, the average price increase of established drugs on the market is consistently well over the rate of inflation, with 2022 data demonstrating a 15.7 year-over-year increase. To be clear, hospitals do not set the price of drugs. Like retail consumers, hospitals are subject to the whims of drug manufacturers. If you have concerns about the cost of drugs, you should direct your questions to the companies that set the list price for their products, and you should ask them to be more transparent about how their prices are set. You and your constituents deserve transparency. And as a reminder, because I am who I am, one of the ways that you can positively impact drug prices in the state of Michigan is supporting the 340B program. And with that, because we're going to talk a little bit more about supplies and additional costs, I'm going to turn it to my colleague Laura to spend some time on those issues.
All right. Anything from Elizabeth before we go on? Questions, comments about 340B? Well, Mr. Chairman and members, I want to thank you again for this opportunity for us to speak with you today. And, I want to be sure that no one thinks that we are here to give you a list of complaints about or excuses about why healthcare is expensive. These are just the reality that we're working in, and it includes, not just hospitals and our colleagues in the insurance industry, but, consumers we know are really bearing the brunt of this. So we are well aware, and, please don't take this as, our unhappiness overall. So I'm just going to say one other thing about drug costs. When Elizabeth was speaking, I forgot about this. So I will speak about drug shortages more generally. But a couple years ago, we had a terrible shortage of 2 chemotherapy drugs. One's called carboplatin, one's called cisplatin. Cisplatin was actually patented at Michigan State University in 1965. And because of the shortage, the shortage happened because there were 5 places in India where they made this drug. One place said, for us to be in compliance to create this drug is more expensive than we get paid for the drug. So we're not going to do it anymore. So 20% of the market was taken, or 20% of the drugs were taken off the market essentially. And in that time, there were several months where things were really difficult, and nobody wanted to say, these folks can't get their chemo. So as an example of what does this mean in terms of drug pricing, and this is not even necessarily the manufacturer, but what's on the market. So one of our mid-sized hospital systems went to the market to get whatever they could for their patients. Carboplatin, which is newer, has fewer side effects, might be a little bit more effective in some cases, not available at all. There's just none. Cisplatin, the older drug, more severe side effects sometimes, was available. And this pharmacist in charge of this health system bought everything he could, which was a 3-week supply. He usually spent $11 a dose. To buy that 3-week supply, he spent $550 a dose. But there's no way you're going to say no to the people who need that drug. Let me assure you, none of the reimbursement in that situation changed. That's just the type of thing that happens when prices increase dramatically in some of the areas that hospitals are buying. So a little bit more about drug shortage. You might recall of hearing that we had an IV fluid solution shortage after Hurricane Helene. That closed down a production facility in North Carolina. Unbelievably, they had the same problem with Baxter at Hurricane Maria when it shut down production in Puerto Rico. So it's, on the one hand, you might say, well, repatriate that stuff. We do have it patriated here. It still wasn't enough. So supply costs are also growing, and supplies can be everything from the gloves that we're using in every place in the hospital to tubing, but it could also be, mechanics and things like that. Everything is going up quickly. From 2019 to 2022, supply costs went up by 18.5%, but by more than 30% if you're just talking about the emergency department. And something that's really concerning for all of us, and I'll be the first one to say I don't have an answer to this, is we are seeing patients who are sicker, meaning they have higher acuity, and even worse, we are seeing patients who are younger. We have statistics that show us we suddenly have a significant increase in the rate of heart failure. Now, you've probably had an elderly relative who's had heart failure. How about heart failure on the rise for people between 45 and 54? We also have pretty bad early onset cancer rates for certain cancers for young people. So those are a couple things that, you know, the longer people have to stay in the hospital and the earlier they start needing that level of care, the more difficult it becomes. You know, I want to show you this is a little bit of a tough graph to read. Despite this difficult environment, you can see Michigan here in a study by the RAND Corporation. I think this is version 5. Shows, and this is the most recent data that they had available, so I think they produced this in 2024, but it's for 2022 data. When you blend our inpatient and outpatient commercial paid rates, so what commercial insurers pay hospitals, we rank 47th in the country, or 48th in the country. We're third from the bottom, and we are one of 5 states that the average as a multiple of Medicare is below 200%, the average of inpatient and outpatient payments. Now, let's talk just a minute about Medicare. You might be like, well, you know, Medicare's doing well. No, you'll see that on this slide, Medicare overall in the United States, what they pay in rates is billions of dollars short compared to what the cost is of caring for people who have Medicare coverage. We also want to make clear that there's a significant administrative burden. You've probably heard a lot about prior authorization. We have to appeal denials of care, and there are many payer-imposed compliance requirements that they're simply expensive to manage. So in summary, as Elizabeth said, we're open to everyone every day, regardless of ability to pay. It's a legal obligation that when someone presents themselves at the emergency department, hospitals must care for them. It's also the core mission of our hospitals. You know, we're the only part of the system that is required to take care of everyone, but it's really part of what we do. We provide, you know, care regardless of your illness, your temperament, your referral, you know, where you're referred from, any other factor, and we're not asking for anybody to change that literally ever. So, you know, we join you in our efforts to address the challenges to healthcare access and affordability, and looking for ways to keep Michigan a high-quality, lower-cost state. I don't want to say low cost because I don't think anybody's truly low cost, but we, you know, we're in it to, you know, figure out how to make things better as the association and on behalf of the hospitals that Elizabeth mentioned. So thanks again for your time. Appreciate it.
Well, thank you. And, you know, this is, as you know, because I know you follow the committee, but, you know, we've made a concerted effort this year to really address learning about cost drivers in all facets of healthcare, right? Not just the hospitals, but with drug manufacturers, PBMs, you know, you name it. We're trying to wrap our heads around all the things that we do here in the legislature that can raise or lower costs for people in Michigan. So, and I think there's probably a little bit everywhere that we can probably look at. And, you know, I think it's something that our vice chairs and I have really discussed about how can we benefit the people, you know, and you guys offer a fantastic service. Where would we be without hospitals, right? I mean, it's a huge aspect of things, and we need you to keep your doors open.
Could I mention something about, you mentioned the PBM. So late in the pandemic, one of our pharmacists in charge, actually I think it was University of Michigan, said, you know, just at the same time that we're having a terrible shortage of pharmacy techs because we're not producing as many as we used to produce, and we actually need many more. And it's really because of, I mentioned the payer-imposed administrative requirements. And I understand, you know, people are trying to say, let's make sure that the people that are getting the drugs that they need and that kind of thing. So there's so much work for pharmacy techs related to those changes that registered nurses were having to leave the patient care floor to go down to the pharmacy and pick up drugs for their patients, which is terrible on many levels. You don't want the nurse to leave the floor. You don't want that drug to be managed that way. It's a very bad way in terms of making sure the right drug gets to the right person in the right amount, those kinds of things. This literally happened to me when my husband was hospitalized about a year later. I watched the nurse on the floor, on the phone, say, yep, can I come down and get that? Sure. She said, I'll be right back, I'm gonna go get it. It wasn't just a story, I watched it happen, and I wanna agree with you in that No one is sitting in an office saying, I know what I'll do. We'll really trick them up and like make this requirement. They're looking for how they're gonna do their job, but it is the kind of thing that has consequences that go way beyond just how much things cost.
Okay. Well, I would imagine we probably have some questions, but I guess being the chair, I get to start off. And I think I warned Ms. Cutter here. So there was an article that came out recently in the Detroit Free Press. I think it was May 30th of 2025, or at least that was the updated version. And it talked about how some Michigan hospitals are marking up drug prices by up to 800%. Now, we know statistics can go up or down based upon, what the story is, right? But I think it begs the question. So I think, just to quote parts of the article, the analysis compares the prices of 3 specialty drugs. As we know, there's tons of drugs. We could probably pick out a whole bunch of different ones and get different results, but 3 specialty drugs across 53 Michigan hospitals that suggest that even within a single health system, the charges billed to patients and their health insurance plans can vary by as much as $14,600 for the same medication at the same dosage, and were sometimes more than 800% higher than the manufacturer's average sale price. And I think you were quoted in this article, so I figured I'd bring it up so you could address some of it, and and maybe we can go back and forth on some of the numbers that came up, but maybe holistically, I'll let you.
We have significant challenges related to the claims that were made in the press conference that generated that article. We have access as the association to the same data set that they told us they pulled this information from, as well as a number of our hospital systems. We have not been able to duplicate those findings. In fact, one of the drugs that was named, and as one of the hospital systems said, they look like they took this drug that we use as an outpatient drug and are using it with the inpatient setting and pricing, which almost never happens. So we're like kind of confused on why you would choose that, because like maybe 3 times a year a person receives this type of care in an inpatient setting. In that in that particular case, the health system said it looks like they're using the full inpatient payment for everything that is part of that stay as the pricing for this drug. Now, I know that the organization that promoted this is saying that's not true, that's not how we looked at it, but this comes to me from a CFO who's really savvy and knows what she's doing. So I think there are some difficulties with the way that this was all constructed. The other thing I would say is, we don't turn around and we can't. I shouldn't say we can't. You might say to yourself, I remember I had a person visiting a hospital, and we have the proverbial, a bottle of aspirin, 500 aspirin is like $1, right, or $10 or whatever. How come it's so expensive? We keep drugs in very sophisticated machines. You have to fill those machines. They're electronic because you can't just pull drugs out of them. You have to have a code. The drawer pops out. You have to be sure that the drug that is in that drawer is the one it says it does. If somebody's allergic to aspirin, it can't be aspirin. It has to be aspirin in the aspirin drawer, not in the Tylenol drawer. There's a pharmacist who's filling that machine. There are registered nurses who are taking that drug out and then administering it to the patient. It's not we don't simply have wholesale pricing that then we can translate, back to just getting the same cost for it. And finally, I'll go back to my example of when we have a terrible shortage and people need chemo, you're going to pay what it costs, and it might look like this average sales price is $11, but for those 3 weeks you paid $550.
So so I guess my question is, how do hospitals set this pricing? Especially, the article alludes to, there's health systems that are in different locations throughout the state, and there's huge disparity in cost between the different facilities. And so how do hospitals decide what that pricing is? Why, if this is even semi-accurate, why is there such a disparity in the pricing levels? And then I might have one more follow-up for you.
So let's start with why are things different in the same system? So this hospital system, My Michigan, I don't believe was referenced in the article, but I'm going to use them as an example not of drug pricing, but of systemization. And they bought or acquired a few of the Ascension hospitals. Ascension decided to exit Michigan, and so I think they acquired 3 of the Ascension hospitals. Hospitals generally do planning for their service lines, building, expanding, contracting service, et cetera. Those are like 5-year plans. And those new hospitals were acquired just about a year ago now. There's no way that they have obliterated their legacy pricing to match what was My Michigan. And in fact, My Michigan, a year before that or so, they became the controlling interest of a hospital in Sault Ste. Marie. And a few years before that, they were the controlling hospital. They expanded from Midland to Alma and Clare and Gladwin. So it's a very long process to get everybody just on the same electronic health record when you are merging systems this way. And pretty much everybody that's in that article is a system that is probably still within that 5 to 10 year planning phase. And one of the hospitals at My Michigan, I will again not mention exactly which one it was, and this is not specific to drug prices, but we were having a conversation about your charges, why, can you do anything to lower your charges? And the person who was running the hospital at the time said, my payments from commercial payers are linked to the charges. If I reduce my charge, then I reduce my payment because it was based on a percentage. I don't know how prevalent that was at the time, and certainly that was many years ago, but there are all different ways that folks have negotiated charges and how to manage or not negotiated payments. The other thing I want to say about the original article that you mentioned is there's a Medicare regulation, and I can find it if you needed it because we talked about this all the time in No Fault. We must charge everybody the same thing. That's kind of a requirement of the federal government under this Medicare regulation. So there might be a reason that there's a very unusual charge, like let's say something's $25,000. What the hospital takes in payment varies by payer. Everybody gets charged the $25,000. Somebody's going to pay $10,000, somebody's going to pay $1,200, somebody's going to pay $21,000 for that, but everybody has to be charged the same, and then these prices from commercial payers are negotiated. On the other hand, payments from Medicare and Medicaid are taken. We're price takers in that case, and that's about those two government programs cover roughly 50% of Michigan residents or citizens.
I am going to be a mic hog. I'm sorry. So let's go back to not systems that have just acquired a facility or whatnot. Let's talk about, so in a large healthcare system, let's say the facilities that we're talking about have all been in existence for 15 years within that health system. Okay, so they're all ones that have been around for a while, should be on the same, electronic billing cycle, this and that. Should all of those that are that old all be the same billing then?
So maybe, but again, how you structure the costs of the facility or the things that you do inside of that facility over to the services that you offer. Let's say that it's something that you do some of it in a smaller facility, but you don't do a lot. So your fixed costs are going to be higher. In fact, maybe they're 50% higher because there's certain things you absolutely have to have in order to do that service. But you do 1/3 of the rate at the larger hospital. So you're going to likely assign the cost of doing those services across a lower volume. So by definition, it's going to be a higher rate because you have fewer people to spread that fixed cost over compared to a place where they might do, you're doing 300, they're doing 1,000, and the fixed cost might be, very similar, and it's going to look different.
Okay, thank you. Vice Chair Carter, I'm not going to hog the microphone anymore. You want me to go Fitzgerald first?
Fitzgerald first, please.
All right. Rep Fitzgerald.
Thank you so much for being here today, and thank you for your presentation. I'd like to, if we could, move back to the workforce slides. If we can do the demand slide, that would be great. Yes, this one right here. Obviously, we know that there is a workforce need and a workforce challenge here in the state when it comes to healthcare. You mentioned some of those headwinds in terms of, I think you said swimming upstream when it comes to the competitive nature of the job market right now, I think the competitive nature of education as well in terms of where we're attracting students to focus their studies. In terms of nursing, obviously there's been a great deal of conversation in this town around nursing and how we help to change the tide, if you will, for that swimming upstream in terms of how our nursing staff is able to be supported, acknowledged, and also then, I think, grown here in the state. Nursing is one of those degrees. I graduated high school in 2009, and I felt like 1 in 3 people were saying that they were going into nursing at the time. It felt like there was going to be this huge talent pool of well-qualified people who were looking for a profession that could satisfy them both financially as well as emotionally. It's a very rewarding job when done well, and you get that satisfaction from your work. My question is, how is it that we can maybe change that tide again? And this is an open-ended question. I don't know the answer, but I'd love your thoughts about how we can, again, reestablish that as a vocation and an education that we want to see participants in, and then again, maybe again, a longer-term career pathway as well. We talk about burnout, we hear about burnout, so that the degree only goes 5 years instead of 35 years. I'd love to just hear your open-ended thoughts on
Yeah,
that.
so Elizabeth, this is her area of expertise. I just want to give one little factoid, which is in the second half of the pandemic, I guess I'll say, this legislature appropriated first $225 million and then $75 million towards nursing retention and recruitment and helping us get and keep nurses. And I think that made an amazing difference. We talked to other states where they said, you would be amazed, we got $10 million. And we were paying outrageous sums for agency nurses and such. And although we don't have it in this slide here, our retention rates in Michigan are 2 to 3 points higher than what they are nationally for nursing. And I really attribute it back to the partnership that we had with the legislature to help us get that jump started back then. So thank you.
Yeah, I'll highlight a couple other items too. I mean, so this one is our vacancies, but this one is how many people we've hired. And as you can see, nursing is that top one again. And there's a couple reasons for that and a couple big things that this legislature and that our partnerships have really created opportunity in. One of them is a partnership between the community colleges and the four-year universities, where community college campuses can now offer nursing degrees on campus. They partner with a four-year university, so an individual who lives in Alpena doesn't necessarily have to travel downstate to finish their nursing degree. They can finish it at Alpena Community College, and they can graduate with their nursing degree right there in their community, and then go work potentially for My Michigan in Alpena. They can stay in the community, they can be there. We worked really closely on that partnership. We also worked really closely on appropriations that help support things like capital build to make sure that community college has the space. As you all well know, healthcare careers require specific types of space in a college setting. You need to be able to have lab space. You need to be able to do important didactic work. So they needed that money, but it also meant that there was an opportunity for us to fund things like scholarship and loan repayment. We continue to focus a lot in that space too. So outside of just the community college and four-year university ADN to BSN partnership, we've worked really closely on the Achievement Scholarship as well as the Reconnect program. One of the huge wins that we saw with work through the legislature was adding in high-demand healthcare careers to the Reconnect program. So one of the things that Reconnect had not previously contemplated was things that were sort of healthcare credentials that didn't meet the 150-hour mark and were instead things like a 16-week course to become a phlebotomist or other types of patient care techs or medication assistants. While that's not nursing directly, that means that a nurse has more people on her care team to take off some of the labor and work that Laura was referring to. It helps when you have people who can help run to the pharmacy or help with room changeover or help with patient discharge to walk through a patient's experience and make sure when they leave the hospital they're going to be super successful and that we can unburden nurses. Because you're right, we do really want to address that. And the last thing that I will note is really around the space of violence against healthcare workers. This is a huge issue. It's one we worked a lot on last term in terms of increasing the penalties for assaulting a healthcare worker, but that work's not done. We really need to focus our efforts on protecting our healthcare workers. You should feel safe when you come to your place of business, and you should feel especially safe when you're a person who's on the front line of caring for your community. So we are really focused in that space. There are a number of bills that were introduced to the House just recently that deal with that. They would increase that penalty again and bring it up to a felony, making sure that our nurses, our doctors, our phlebotomists, everybody that's a volunteer, a patient, whoever is in the hospital can know that they are safe in that space and that there is a deterrent opportunity to make sure people recognize you can't come into the hospital and assault somebody. You can't harm them. They are your caretaker, and they're somebody who's here and committed to making sure that you have a great experience, not somebody that you should be harming. But that's one that we would charge this legislature to continue looking at, because when you're thinking about opportunities to make more of these numbers, so more of the higher numbers, the first thing we have to do is make sure that we're continuing to keep them safe. It's something that we're doing. It's something we're prioritizing investment in. I mean, I think you'll see from our members a very large priority on investing in security and opportunity to make sure our folks are safe, but we need the legislature to help us do that too.
A follow-up, if I might, Chair?
Yes, sir.
Thank you. I love what you're talking about, and talking about how we can again continue to make the healthcare efficient, affordable, and the like. If you can move forward just 2 slides, I think it was talking about total cost, or maybe it's backwards. It was that one right there with the pie chart. Right now, labor is 56% of total cost, and if we look at increasing and continuing to hire to chip away at those workforce needs, do we see that there's going to be an inherent rise, though, then, in that cost? I don't necessarily think we'll see a rise in demand, but we would see a rise in cost associated with filling those roles, which we need to do to make sure that, again, healthcare is safe, effective, efficient, all the like. But are we going to also see a rise in total cost when that 56% becomes 62%?
I'm gonna quote a colleague. Hospitals are just a building other than the people inside of them. So labor, to some extent, is always going to be a large cost, and it's something that we continue to prioritize. I would defer to Laura if she has additional comments too, but I mean, that's one where we are competing in a market that is extremely competitive. I mean, we're competing against everyone that does anything. I mean, hospitals employ everyone from attorneys to marketing to food service to patient care. So we're competing against every other entity that does that too. It means that we have to stay super competitive. It also means because we're open 24 hours a day, 7 days a week, 365 days a year, got it right that time, there's always going to be that high cost in labor. So I don't know that we see that one necessarily ever decline, but truly that's one that matters a lot, but it's really helpful to contextualize, why is cost the way it is? Well, we compete in a really, really big market.
And Laura, before you jump in here, I think that this is a yes and, right? Yes, we need to fill these roles. Yes, we need to ensure that healthcare is efficient, and we need to consider other ways that we're controlling those costs, because we need those labor increases to fill those positions.
Yeah, unfortunately, I don't think we can agree on the perspective that we won't have increased demand. What I always say is that the one thing Michigan is always making more of is old people. And I believe we are like a net importer of 85-year-olds. Yeah.
This is all
But, people leave Michigan and they go someplace where it's, warmer to live and everything. And then when they become more frail, elderly, they return home. And this is where family is, and they take care of them. So we have, I think, a higher percentage of that part of the population. And then what I said earlier is, you would be, I think, quite amazed at how much has been pushed out of the inpatient setting to the outpatient setting, but those people who are in the inpatient setting are sicker. And then, as I mentioned earlier, I have way too many younger sick people, seriously ill people, and I haven't studied it enough to know why that is. It's frightening that our young people would be in this condition, but I think that's part of why we have a problem with demand.
And let me just clarify too, the demand point was an increase in nurses won't cause a greater demand on the system.
No,
there is a
agree on that.
greater demand on the system because of other natural factors occurring, including an aging population.
But that's another reason why, especially if acuity goes up, like you had to double the number of ICU nurses that you need because you have more beds for ICU because people are sicker. ICU is a 1-to-1, one nurse to one patient, whereas the med surg floor is 4-to-1. So it gets expensive really fast.
So if you have family members that are interested in pursuing a career in healthcare, we would love to help them. You can visit the Michigan Healthcare Careers Campaign website that the MHA helps make sure is out there.
Thank you. I almost gavelled you when you called me old, Mrs. Cutter.
To be very clear, I think I referred to you as a youth.
You did. You did. So did Mrs. Harris. With that, I'll pass the microphone over to Vice Chair Tisdall.
Very quickly, you brought up health provider shortage areas. Are all of your member hospitals assigned a HEPSA radius? And if so, can I get a copy of that?
Yes and yes.
Thank you.
I think there will probably be a few hospitals that are not in a health
Correct.
professional shortage area. That doesn't mean there's not a health professional shortage area almost contiguous. Like, this was many years ago. Eaton County was not a health professional shortage area, but contiguous counties were. So, I mean, in our state, the next county over is not that far. So they might
Yeah.
not physically be in this, but they're probably serving this patient.
Yeah.
Yeah.
It'd be helpful just to visualize.
Absolutely.
Thanks.
Of course.
Can you send that to all of us? I would love to
Surely.
look at it too. I'm
And
visual as
there's-
well.
There's two, one is a there's two designations, one medically underserved area, an MUA, and then also the health professional shortage area, and we'll make sure that you guys get all of that for both of them.
Thank you. I appreciate it. With that, Vice Chair Carter.
Thank you, Mr. Chair, and I have 3 questions that I'd like to ask. Thank you for your testimony. I appreciate it. There's been strong allegations that the current program is departing from its intended purpose, which is to help patients with access, and I'm referencing the 340B program, which is to help patients access their medicines through discounts provided in the program. How can we ensure that the patients are the main and true beneficiaries of the program?
At risk of being too cheeky, we could pass Senate Bill 94. No, I mean, I think if you talk to our members about the role that 340B plays in their opportunity to support their community, I think what they would tell you is it is one of the foundational elements that they have to make sure that discount programs exist, that financial assistance programs are extremely robust, that individual community health needs are met. So one of the, I think, primary hallmarks of the program and one of the huge advantages of the program is it is not specific about how you use those savings, which means each of our individual members that are eligible to participate in the program can reflect on their community needs, what their patients need, what their communities see. Oftentimes, that's things like utilizing the Community Health Needs Assessment, which for nonprofit hospitals you complete every 3 years, and reflecting on what's in the CHNI. So is it that we need to make sure that we have diabetes programming? And so 340B can go to diabetes programming. Is it that in our community we have a number of people who are food insecure or we're a food desert? How do we make sure that we have a food pantry available or a food pharmacy? I'll use Karmanos for an example. I think they're a perfect example in this case. Cancer care is really expensive. It's really expensive, and a cancer diagnosis is life-changing. What Karmanos decided was we can use 340B to make sure that people have a $0 copay for cancer care. I mean, that's a huge deal. But that's specific. Not everybody's going to do that because it doesn't make sense for every hospital. Not everybody does cancer care. So I think for us, what we see as a huge benefit of that program is the ability for us to make sure that we're reflecting really specifically on what each community needs, and then we're having the ability to do that really well, to use those 340B savings in a way that makes sure that patients are having access to care. So like for a rural community, it may be things like labor and delivery. Like 340B supports labor and delivery, and you don't have to drive 3 hours to the next place where labor and delivery might exist. Again, the cancer care opportunity would not translate in that space. But for the UP, it makes really good sense to keep labor and delivery open. So there's not a direct requirement that it go in a specific manner, but we think that's a good thing. We don't think that's a bad thing. We think that means that patients in Michigan have access to care that otherwise, if 340B didn't exist or if it continues to be eroded, we would lack very significantly.
Thank you. Follow up, Mr. Chair? I almost said Madam Chair. Okay, since the 340B is a federal program, has there been any work on the federal solution? Given that the current environment at the federal level, what do you think the future holds for the 340B program?
Do I get a magic 8 ball for this one?
Yes, you do.
Yes. So, I mean, I was sharing this with the chair a little earlier. This dates me. I'll become an old person now. I think I've been working on 340B related issues for the better part of 10 or 15 years now. And I have seen rare occasion for something to get truly momentum. The last time that we saw significant change in the federal level on the program was in 2010, when the Affordable Care Act was signed. There was inclusion of a couple new hospitals that became eligible in the program. That would be things like critical access hospitals, so hospitals that are in typically pretty rural areas, and that but for those hospitals, patients would really lose access to care. I have not seen significant change at the federal level outside of that. So it's been 15 years since we've seen them accomplish a task. There were a number of proposals during the last congressional term. We were very engaged with a number of senators. There were about 6, actually, who were working on a piece of legislation that we really liked. Created a lot of really fantastic opportunities for the program. But I mean, to be very clear on the pace of what happens at the congressional level, we spent 2 years working on that and it never got introduced. It takes a really long time for things to change at the federal level. I think a huge reason why we have spent a lot of time at the state level is you're far more nimble. Your ability to accomplish a task and fill in the holes is a lot faster. We have an opportunity as a state to fill in some gaps where the federal government is just not acting. I mean, if I had a magic 8-ball and it said, you know, like, are they going to do something about this? My response is probably like, outlook is poor. Yeah, Laura does a lot of our federal advocacy.
So the 340B program has no relationship to the federal budget deficit spending anything. It's a relationship between drug makers and hospitals. So right now in the federal government, you're seeing a lot of focus on finding savings and where they're going to make expenditures. And 340B is not a part of that calculus because it's not taxpayer funded.
One last question, please. And this is for you, Ms. Apple. Sure. In the example you just gave about the list, you stated that list prices are the same for everyone. Is that true?
I did not say list prices for drugs are the same for everyone. I said what hospitals charge anyone is this for, like, let's say that somebody came in and had a one-night stay to have a cholecystectomy, which is having your gallbladder removed. And they spent one night there, and it was done laparoscopically, so the tiny incisions. That charge is the same charge across, assuming there's no complexities, because there's always, you know, unless there's, you know, some problems that the person might have that are not related. You know, somebody might have diabetes, and that's difficult to manage, whatever. Charge everybody the same, but the payments that you accept are different across the board, and they are negotiated payer by payer. They are somewhat, to a certain extent, hospitals are price takers when it comes to what they're paid for Medicaid and Medicare. And there's one exception to this negotiated rate thing, which is when Michigan passed Public Act 107 to implement the Healthy Michigan Plan, the legislature included in that a provision that says if you, regardless of what the charge is, a person who's 250% of the poverty level and below cannot be required to pay more than 115% of Medicare if they're paying out of pocket. So those are some examples of where the charge is the same, but the payment is different.
I think you clarified a lot of what I was asking, except for one thing. What about our uninsured? How are they treated?
So as I just mentioned, for people who are uninsured, and if you're uninsured and at 250% of the poverty level and below, then you cannot be required to pay for whatever service it was, more than 115% of what Medicare would have charged. Okay. And remember, we were looking at the, you can see here that in terms of what, back one. There we go. Okay. In terms of how Michigan's commercial payers relate to hospitals, on average, they're paying just under 200% of Medicare. So that's about, that's 85% less than what a commercial insurer would pay. And that's the maximum that a hospital can take. Some people might also be eligible for charity care, which makes the price zero, and things like that. So those, I guess,
that was a good point.
Yeah, I would augment, in addition to the charity care, almost every single, if not every single one of our members, and I say almost because I haven't asked every single one of them, but everyone we've asked tells us they also have financial assistance programming. So if at any point in time you receive a bill, you can call the hospital and talk to them and say, I have concerns. I'm concerned about my ability to pay and I need help, and we're here to help to do that.
Thank you. Thank you.
Of course.
Thank you. No other questions on this side? All right, I do have one more, just because I see the drowsiness in Rep. Neyer's eyes, so I want to keep him going.
Blame it on Rep. Neyer.
All right, so we talked about, and I think you guys have mentioned it, I think we mentioned it, about drug costs, and and I don't know if everyone understands how 340B works. And even if we're talking 340B drugs, non-340B drugs, how do the hospitals set their pricing on that above what the drug manufacturers are charging you? And then how does that play in with 340B being able to buy medication down here instead of the normal rate? And then how does that translate into savings for Michiganders? I guess, how are we taking this money, putting it to good use, and keeping healthcare costs dialed down?
So, like I said, price setting or charge setting is one thing. Payment is another, and payments are negotiated. I would say that in many situations, for example, a couple years ago, we had a new vaccine for newborns for RSV. And my understanding is that most commercial payers were like, absolutely, we will cover the cost of that vaccine. It'll go into your existing DRG, meaning there was no change in recognition of the cost of that vaccine for newborn care. If you got paid,
Do you want to define DRG?
I'm sorry, the set price for a I was going to use like labor, like you gave birth to a baby, and your payer on your behalf is going to pay that hospital $5,500 for that situation. Now you said, I would really like this new vaccine for my child. Absolutely. No additional payment. It's $5,500. So, in that case, what the price you set for the drug is irrelevant, right? Because it's not going to change what you're going to get from your payer. So where we in terms of how our drug prices set, in many instances, they are also part of the continuum of care. So it's a bundled payment, and that might just be, again, built into that. Then I'm sure there are times when people look at what the drug costs and what they would say are the administration costs, administering the drug, taking care of the drug. Some drugs have to be kept cold, some drugs can't get cold, things like that. So I would, in some cases, there's just got to be an individual decision about how to manage a drug, and I would say that the more you get into the higher cost drugs, the more likely that is. But also, payers make decisions about what they'll reimburse for those things, and you can decide what your prices are, but what your reimbursement is very payer related.
On the
Go ahead.
340B side, there's a number of issues that go into it too. So you're right, that program allows us to purchase a number of outpatient drugs. So for this group, if people are not familiar with my favorite combo of numbers and letter, that program allows certain covered entity hospitals. So you'd have to be baseline a nonprofit hospital, and then a certain type of nonprofit hospital. So think critical access hospitals, hospitals that serve a large proportion of Medicaid patients, cancer hospitals, children's hospitals, rural referral centers. You are allowed to purchase certain outpatient drugs. So like Keytruda is a cancer drug. It's an outpatient administered drug at a significant reduction. That reduction then allows you to generate a benefit associated with that. So it's patient agnostic to some extent. So if I go in, I, Elizabeth Cutter, need Keytruda, I go to my pharmacy, which works, actually I'll go to the hospital pharmacy for this one because it's a specialty item. I go to my hospital pharmacy, I pick up that drug, I have great insurance because I work for a fantastic employer, I pay my insurance copay, and I move on with my life. It is not me necessarily who sees that right there. What my hospital then sees, though, is they had the opportunity to purchase that drug at the 340B price, and then they were reimbursed either A, at the 340B ceiling price, or B, at the regular commercial insurance rate. And then that benefit is what they can say to, we'll use Laura. Laura also needs Keytruda, but she has no insurance. So the hospital can say, we're going to make sure Laura doesn't pay any different amount than Elizabeth paid. So Laura can go in, she can get Keytruda, and that 340B benefit makes sure that Laura doesn't pay $700 out of pocket, and that Laura has access and Elizabeth has access, but because of our differing circumstances, we don't see a different thing occurring. So that's what I would say in terms of that. There are a number of things that go into that existence, though. I mean, the federal government plays a huge role in what happens on the 340B space with regard to what we're eligible to do, what we're eligible not to do, and we spend a lot of time, and our pharmacists in particular spend a lot of time making sure that they are compliant with those rules and regulations. In addition, we can't duplicate those discounts, so you could not be eligible to get a Medicaid rebate on a drug and then also a 340B discount. That is illegal not only in the state but also at the federal level.
Do you see, as this committee explores the cost drivers on every facet of healthcare, not just hospitals, but, like I said, insurance, PBM, whatnot, do you see that program, if hospitals are able to buy down here, charge insurance the full rate, does that affect premiums on insurance for Michiganders across the state?
I think what Elizabeth said is really important, which is the negotiated payment that you get is the negotiated payment. It doesn't go up because it's a 340B drug. I mean, you might be able to purchase that drug at a discount, but you're going to get reimbursed for that drug. What you're going to get reimbursed, what you've negotiated with your payer. It's not I don't know of any hospitals that have told us we negotiate a different payment rate for the services and pharmaceuticals that we provide to patients based on whether or not that's a 340B drug.
But the purchasing rate is what changes, so it changes your margin, right?
Correct.
Which if you have this margin, and I understand
Yep.
some systems are using it for programs, this or that, but we have no mandates that lock that in, so we know it's going to those programs, right?
I think it
So
Because when we look at margins, whether it's a profit or nonprofit hospital, they're all over the place, right? And I think it depends on regional issues and
Well, we are
whatnot,
one of
but-
4 states in the country who are negative margins for hospitals. So as of last year, we were one of only a handful of states that hospitals reported negative margins. So, I mean, if we're going to go down the margin pathway, I would welcome our other healthcare stakeholder
Sure.
colleagues to share what their margins look like, because ours last year were negative. And I don't know that that's the case for others.
Well, I think you have one or two that are in the 30s.
I
Plus
don't
30s.
know about that. I can't
So-
speak for their individual margins.
Sure, but I
So,
guess
I
my
think-
question goes back to, though, if the drug is being paid for down here, but you're still charging insurance at same rate that you would if it was a
Paid, not
non-340B
charging,
drug.
paid, we're getting paid.
Right. Do you see that, in your opinion, as affecting the ability for us to lower insurance rates for people?
So I would say that being able to have a situation where drug costs are lower for hospitals, instead of going through this list of all of the things that are pushing up prices, lower drug prices to hospitals, I think would alleviate the need to raise rates further because their costs aren't as high. And it also means that that margin can help offset all of the places where, like as we showed, Medicare rates don't cover the cost of taking care of someone 100%. So when you have the shortfall in those payments, then things like your margin on 340B can help you just keep taking care of everybody. Otherwise, you would be even shorter compared to some of the payers.
Thank you. And I think Rep. Aragona. All right, Vice Chair Carter.
Well, thank you, Mr. Chair. Mine is just a request, because one of the areas that I've been getting a lot of, I guess, interest in is the FQHC area, what 340B programs, services that they provide. And Mr. Chair, I would ask at your discretion, of course, maybe in a future meeting, that the Hospital Association do a full presentation on what the charity benefits they provide to FQHCs.
So I would ask, if you want to talk about FKHCs, I would really encourage you to reach out to the MPCA, the Michigan Primary Care Association. They represent all 41 FQHCs here in the state, and they do a really fantastic job. And they're going to be able to speak about what the FQHCs do and their experiences a lot better than we can.
Okay, wasn't asking for what the FQHCs, what they do. I'm familiar. I'm asking about charity benefits.
Yeah.
Because that's been the area that's been impacting a lot of the decisions that we're making.
We can, well, certainly the MHA can speak to this, but we could also, connect with our members about every nonprofit system has a charity care policy and works to provide those services or to provide those benefits to folks who need them. And I think we could find some really good examples of how charity care policies work.
We're also happy to follow up with our community impact report, which details all of the community impact that our members make across the state. So we produce that annually, and that includes things like that $4.5 billion number that we previously cited about community impact and charity care programming. Yeah, of course. We can absolutely do that. That's easy.
Thank you. Rep. Aragona?
Thank you, Mr. Chair. Thank you, ladies, for being here. I just have a quick question. Just wondering if the hospitals had any opinion on the road funding debate that's going on here in Lansing. It was more for Ms. Cutter.
Oh, I'm sorry, go ahead.
I love roads. They're great. We drive on them.
I was pretty much gonna say, we like good roads.
Yeah, roads
We're
are.
100% in favor of good roads.
We are a willing participant in all conversations, Representative, and we're more than happy to
Great, thank
to
you.
share information. Yeah, 340 better roads.
I knew the
That's
vice
what the
chair would.
B stands for, is better roads.
All right. One last question is just, I really think the committee, and it doesn't have to be here, it can be follow-up, but I think we'd be really interested in the hospital's perspective on what mandates and regulations are we putting on you that are helping to drive up cost, right? And maybe where are some things that we can look at to address as we're kind of looking systemically at healthcare and how can we help with that? So we'd love your input.
We look forward to that and certainly have ideas on things that are administratively burdensome.
Well, thank you both for being here. I appreciate you being in the hot seat. And with that, can I have a motion to excuse absent members? Representative Fitzgerald makes that motion, and with no further business before the committee, we are adjourned.